Hello, welcome to the sixth and final module of the series COVID-19 and GI Tumors Update 2. Today's session is approved for 0.25 hours of CME, CNE, CPE, and APA credit. The series is provided by North American Center for Continuing Medical Education. My name is Axel Gothi. I'll be the moderator for today's program. I'm the Director of GI Oncology Research at the West Cancer Center and Research Institute in Germantown, Tennessee. And I'm joined by Dr. Alberto Sobrero, who practices medical oncology at Policlinico San Martino in Genova, Italy. And we really appreciate, Alberto, you being here and share your experiences with COVID-19, not least since Italy was clearly the hotspot of in the early phase of the pandemic, once it moved from China to Europe as the first hotspot. We'll take the next 10 to 15 minutes to discuss standards of care in the management of our patients with GI malignancies without compromising outcome in the time of the COVID epidemic. So I mean, Alberto, this already kind of frames the discussion that we need to talk about, because as we all know, COVID-19 had huge impact on how we manage oncology patients and what resources became available. And tell me a little bit what happened, in terms of, where did patients receive cancer care when you got hit in northern Italy with the virus? And do you believe there was some compromise in, management of patients and outcomes of our cancer patients?
Yeah, of course, there was some compromising. Actually, I was very surprised to see how these compromises were understood by the patient population. That was kind of a surprise, because in the usual times, when we are not pressed with special events, usually patients tend to focus even on very small differences, and they don't want to lose even 0.5% chances of being cured, or say 5 to 10% additional response rates in diseases that are lethal. So there was this sort of adaptation. So the major, I was thinking of how to summarize how things have changed. And I could come down with a very extensive list of measures that we have taken, such as forget about the follow-up visits on the low-risk patient, number one. Number two, change to oral regimens as opposed to the classical FOLFIRI for colorectal cancer. Number three, delay the evaluation of outcome CT scans, say, for example, avoid biopsies unless they are absolutely necessary. However, if I have to summarize the major change that has occurred, at least to me, has been a sort of being sensitive to a very important responsibility I have been called to respect, and that is shared decision-making on all the issues with the patient. Let's make some examples here. In the usual times, we actually practice a shared decision-making, especially in the adjuvant setting, okay? But say, take a stage 2 patient, say non-high risk, non-very high risk stage 2, meaning no usual good number of nodes taken out and no T4, okay? All the rest with some other factors. You can talk the patient into saying, I don't want to miss the 2% chance of additional cure rate that I may have by getting 6 months of capecitabine. Or you may talk her into reasoning, well, I'm not so sure that given this very low risk I have within stage 2, I may not get 2% additional cure rate. We do not know those figures. So I have become more open to the patient reaction under the patient stress of COVID, not only our stress. That's one example. Example number two, say stage 3 average risk patient. Well, he has to get chemo, no doubt, because the benefit is too high. So I go down quite strong in saying, the surgeon gave you this much of chances of being cured, say 50, 60%. Be aware of the fact that if you do not want adjuvant chemo, 3 months of Capox, you may lose 19-20% chances of additional cure rate. So in that case, I'm talking the patient into trying to forget his concern about the COVID. When we jump into the advanced setting, and I'm just addressing the colorectal cancer patients, well, I tend to not to make a big deal out of the use of triplet, for example, because you double toxicity and you gain a 10% response rate. And I tell them, if they react in saying, I don't want to lose that 10%, I still emphasize what the risk within stage 4 is of that peculiar condition. And I may try to talk him outside that definition by putting argument against the use of a toxic regimen when it is not warranted.
Right. I think we all make assessments now in a very different risk, benefit ratio discussion with our patients. And I completely agree that, we in this shared decision making, we as oncologists actually have the responsibility to, based on our knowledge, to lead the discussion. You can't just say, oh, let's because we in the end, the patient will rely on our expertise, to also set priorities. And I believe, not compromising outcomes, not really affecting outcomes for patients means we need to know where to fight our battles. Curative approach in adjuvant stage 3 colon cancer is very valuable. That's where we get our cure. That's where we get the 20% higher cure rates. But I completely agree, triplet versus doublet as first-line metastatic disease, the overall survival benefit, if at all, would be minuscule, and the risk would be very high. And this is not just true for colorectal cancers, for other diseases. Do you need FLOT versus FOLFOX, in perioperative management of gastric cancer? And these patients are potentially at a higher risk because a lot of them are cachectic. A lot of them have really overtly immune compromised, have a high risk of blood clotting. Those patients, it's a very different assessment.
Yeah. Actually, we are called to a more pronounced responsibility under one of the 3 domain of evidence-based medicine. After all, evidence-based medicine, as revitalized by David Sackett in the late 90s, is made up by 3 domains. Number 1, the scientific evidence. Number 2, my clinical judgment. Number 3, patient expectations and values. And evidence-based medicine is the summary of the 3. Now, under condition of stress, I think we should empower the patient so that he fully realizes what his values and preferences are in the light of a very deep knowledge that we transfer to them of the scientific evidence.
Right. And, we all have to set priorities. We all have to we need to be very well educated about the benefit of our treatment approaches. And I do sometimes believe that we overestimate what we're actually doing. Like, for instance, adjuvant therapy after liver resection for metastases. Do we really have good evidence that this improves survival, or is it something we're doing because we've been doing it? And again, we need to have a discussion about that. And it could vary from patient to patient. It's also what kind of risks are they willing to to go through. And I mentioned this at a different time point. Patients with cancer have cancer. They only have a risk of coronavirus infection. Now, that is when I talk to my patients, and I have a lot of patients say, I do not want you to change anything you wouldn't want to do, you wouldn't have done outside of the coronavirus epidemic. So patients sometimes demand. On the other hand, I have some patients who are so scared to come to any healthcare facility that they skip appointments, and this is where we try to pick them up with telemedicine in order to follow them and wrap them back into, because, and this is a very different world. As Lacey put, we have a world put under stress, from outside right now. We need to deal with that. Patients really deserve, that we help them make right decisions in conjunction with us. Very good. So when do you think, so Italy is actually doing quite well when I look at the numbers compared to the United States, and I see this discrepancy. The US is opening up and healthcare is being, we do everything the way it was. We have elective surgeries and hip replacements, and our numbers don't justify that. And in Italy and in other countries in Europe, it's a very careful, slow opening of facilities, etc. It has not returned back to normal, right?
Absolutely not. I mean, I cannot walk out of my home without a mask. I cannot, because the first person I run into, 99% of the patients wear masks, even when they are alone, walking in a very large area without anybody. So it's a sort of, as I said in another of these interviews, I really did not expect that type of adherence to a recommendation. Now we have 3 to 10 deaths each day now. We're coming down from 1,000 deaths per day.
In Italy, or were you in Italy?
In Italy. And 80% of these deaths are accounted for by northern Italy. So we still cannot go to the beach, for example. Of course, you find exceptions, but that's still not possible. There has been such a severe lockdown back in March and April, to the point that you could not move from a city to from a department within the city to another one. That was really mad. But I was impressed by how much the patient and the population accepted these restrictions.
So Tennessee had 2,000 new cases since yesterday, and in our state alone, 13 deaths, which is on the lower end of what we see actually in the United States. And it's really unbelievable what's happening here. And it's really going to impact our cancer care for a long time to come. And we are far not at all where you are, and you are still kind of facing all these restrictions, But again, as we said, there's also an opportunity to learn from that, to be better doctors, practice better medicine, run studies more efficiently and more, smarter actually than what we've been doing so far, and roll back some of the regulation and rules that have really taken over the way we practice medicine.
Yeah, more than smarter trials, I would say not those focusing on fine-tuning of something already.
Right. Better trials, more ambitious trials.
Priority to new drugs, essentially.
Right. Okay. Thank you, Alberto, and good luck. And hope hope everything will turn out fine. And thank you to everyone for joining us for the program today. If you have any questions, please submit them in the Submit a Question tab located on the right-hand navigation bar. One of our expert faculty will respond to your query. To receive your CE credit for today's program, please complete the evaluation located on the right-hand navigation bar. You'll then be able to download or print your certificate. And thank you again for joining, and we hope you all enjoyed this COVID-19 and solid tumors 6-week series, and most recently focused on GI cancers. Thank you very much.
Thank you.